Breast ultrasound, indications, technique, and normal anatomy. We use breast ultrasound most commonly for evaluation of a palpable mass. When a woman comes into our breast imaging center and has a palpable mass, whether it is or is not seen on a mammogram, we always do an ultrasound. We do evaluation of a mass on a mammogram. Sometimes on a mammogram you can see a mass that looks like it's going to be benign based on mammographic characteristics, but there's no way to really tell if it's benign unless you do an ultrasound where you can see with almost 100% certainty whether it's a cyst, and if it's a solid mass, you can now have characteristics which can help you differentiate benign from malignant. We use it as the initial imaging for young women under 30 with palpable masses. If you're 29 and come into our breast imaging center, you'll have an ultrasound as your first examination. You may end up also having a mammogram, but it will usually start with an ultrasound. If you're 31 and come in, you'll start off with a bilateral mammogram, and then we'll always do the ultrasound for evaluation of the palpable mass. The most fun we have with ultrasound is when we use it for mammographic correlation. We see something on a mammogram, whether it's a mass, a region of increasing focal density, architectural distortion, or some other change from comparing with previous years. And we will use ultrasound to help us, because sometimes you can do bunches of additional pictures and spot compression views, and I'll show some pictures of that later, and you still aren't able to figure it out, where an ultrasound can help you characterize that region as being something suspicious or something not to worry about. We use it a lot in correlation with MRI and more with PET scanning and other nuclear medicine correlation. Now that MRI has been recommended as a screening test for high-risk women, we see lots of MRIs, and sometimes on those MRIs there will be findings that come up that need to be biopsied or further evaluated, and ultrasound is very helpful. So the patient it won't be that the mammogram leads to the ultrasound, it will now be that the MRI or the PET scan or other nuclear medicine test will lead to an ultrasound evaluation. More and more we use ultrasound as guidance for procedures. Cyst aspirations, fine needle aspirations, for pre-biopsy needle localizations, core biopsies, intraoperative localizations, tumor aspirations, and even ablations using ultrasound guidance. We use ultrasound to evaluate implants, although MRI has become the gold standard, but you can still get lots of information about the breast tissue that overlies the implants on the ultrasound exam. We use ultrasound for focal pain. Now, if a woman comes to our center with generalized pain in both breasts, we tend to try not to use ultrasound because we're not in the business of trying to pick up too many false positives, too many little areas that we won't know what to do with. More specifically, if someone has pain that could likely be caused by something that we're going to see on an ultrasound, such as a cyst or a fibroadenoma or an abscess or one of those reasons which can cause focal pain, that's when we'll do the ultrasound. But generalized pain, we usually try to divert to clinical evaluation rather than doing an ultrasound. Here's just some examples of what we've just been talking about. Here's a 45-year-old woman for routine screening mammogram. And here you can see a region of asymmetry looking a little bit more mass-like than the remaining density in her breast. Conventionally, if you see an abnormality on a mammogram, you're going to start to work it up using the mammogram, and we did some spot compression views, which shows that this is a region of focal asymmetry. It doesn't show many characteristics about it, though. Is it a cyst? Is it solid? Is it normal breast tissue? Here's that spot compression view. The ultrasound actually shows it a whole lot better. You can see it in relief against the normal breast tissue that surrounds it. You can see a lot more of the margins, which are spiculated and angulated. You can see a lot more about the contents. This is not a cystic mass, but it's very hypoechoic compared to the surrounding fat. And this has very suspicious characteristics. And in addition, when you put a Doppler cursor on, you can see that this is not a cyst, if you were wondering that to begin with, but it actually has arterial blood flow. So the ultrasound let us know that this was a very discretely marginated, defined, solid mass that has internal arterial flow, and that needs to be biopsied. And then we can, right then and there, go ahead and do an ultrasound-guided core biopsy, which is what we did in this case, and prove this was a cancer. Here's an example of what I said earlier, which was that you really can't tell on a mammogram whether something's a cyst or a solid mass based just on its mammographic appearance. Here's a very well-defined round mass that looks like it could be something benign based on mammographic characteristics. We did the spot compression view, which shows that its borders are pretty well circumscribed. But we still don't know what it is until we do the ultrasound, which shows that it is not a cyst, actually, and that it does have a very angulated part of its border. This is not totally anechoic, but did have internal echoes. Yes, it has enhanced through transmission. So this is kind of an indeterminate mass. We don't know what this is. We know it's not a simple cyst. It has some suspicious characteristics and some benign characteristics, but it did get biopsied and was proven to be a mucinous carcinoma. So you can't always go by the mammographic appearance. Here's a more vague band of density demonstrated on the mammogram. We did a spot compression view. Makes it look a little less vague, but you still can't really characterize what this is. On the ultrasound, we can actually see in that area that this was a mass that was inside of a duct. You could actually delineate the entire duct and the mass within it. Now, just looking at it like this, you can't tell whether or not this is debris, solidified debris within a duct, or actually an intraductal mass. And that's where Doppler helped us, showing us that there was vascular flow within this area. And actually, this was a solid intraductal mass, which was amenable to ultrasound-guided core biopsy, which was performed, and this did prove to be an intraductal cancer. Again, another mammogram, the medial-lateral oblique views of the right and left breast, a metallic marker placed over a region of palpable concern, where honestly, I don't see any big difference on the mammogram between this breast and the unaffected side. So to further evaluate that, and here are the cranial caudal views, as I said initially in the indications, we always do an ultrasound for evaluation of a palpable mass. Even the spot compression views in this case, unlike the others, didn't really help us out very much. But the ultrasound shows us that this is definitely a very abnormal looking area that looks very different than the surrounding tissue. Hypoechoic, irregular. Doppler shows vascular flow within this mass. Now, using the ultrasound characteristics of benign versus malignant, you would put this in the malignant category because it does not have sharply circumscribed margins. But nothing comes in a vacuum. You have to consider this along with the entire clinical picture. In this case, the patient did report to us that she had redness and tenderness and actually pain over this mass, and that this was in the very same location where she'd had an abscess before. And when we put a needle in this mass, most of this actually did aspirate as thick kind of pus, and this proved to be an abscess. So even using ultrasound characteristics, sometimes you have to go further with a biopsy to prove whether something is, what type of solid mass or what type of suspicious mass it is. Now that we're using MRI more frequently for screening for high-risk women, we're finding just routine screening MRIs picking up findings that we have to look into. So in this case, this routine MRI picked up an area of segmental linear enhancement. That's right here. And using MRI jargon, segmental linear enhancement is what you see when you have, which can be associated, in other words, with DCIS, ductal carcinoma in situ. So yes, this is suspicious enough based on the MRI, but what do? Do you do an MRI-guided biopsy? Well, you certainly could, but that's much more of a difficult procedure than doing a biopsy using either mammography or ultrasound. So when you do a mammogram of that same area, you do see those classic findings of DCIS, further confirming that yes, this is abnormal enhancement, yes, this is a pretty large area of DCIS. You could do a needle biopsy here or an excisional biopsy using needle guidance, but what would be much easier for the patient, in our view, is to do an ultrasound-guided core biopsy. And in the case of extensive calcifications such as these days we are likely to see the calcifications on the ultrasound. We aren't in the business yet of looking for calcifications on ultrasound, but when you see a fair region, chances are with high-resolution equipment, you are going to see those calcifications within this region of ducts on the ultrasound. So we use the ultrasound as a guide for biopsy, which was much easier than either doing it on the mammogram or using MRI. Here's an area where there's a region of asymmetry on the mammogram spot compression view, and it corresponds to an irregular, abnormal, suspicious-looking mass on the ultrasound. Here's a similar-looking region on the mammogram that actually looked to us like it could have some spiculation. And then we did the ultrasound and didn't find anything that looked abnormal or suspicious at all, but rather found normal breast tissue. These are probably some Cooper's ligaments extending into the superficial fascia. And this, to us, looks like just normal breast tissue. And it was. So now you can use ultrasound to not only tell you that, yes, this corresponds to an abnormal mass, but to reassure you that this region corresponds to normal breast tissue. But of course, when you're using multiple modality imaging, you're using a mammogram and an ultrasound, or an MRI and a mammogram and an ultrasound, you have to kind of look back to the image that, or the modality that was the most suspicious. In this case, this was not suspicious. We don't see anything here. We just see normal breast tissue. But on the mammogram, we see something that alerted us to wondering whether or not there could be something suspicious hiding here. So you have to go back to the mammogram now and say, all right, what do you do? Do you compare this with prior studies to make sure this is stable? Do you bring her back in 6 months to make sure it stays stable? There's a variety of options. But what ultrasound helped us with at this point was that we did not do a biopsy of this region, because it's a large enough region that if we were to, certainly should have found something on the ultrasound in that region.